Hello, everybody, and welcome to the Grown Up Girls Report podcast. I hope you are all doing well and have had a great couple of weeks. It has gone so fast. My goodness, time is just flying by. So today's episode is all about menopause and perimenopause. And what we're going to do is we're going to do a deep dive into the science with someone who is an expert, someone who I think the absolute world of. It's Dr. Nindhi Ahilan, and she is a great GP here in Sydney, and she does an amazing job of walking in the integrative world with a whole lot of mainstream medical know-how as well, and that's why I love her. She is the reason why I am here today, and the podcast has restarted because she's just helped me navigate this murky menopausal time. So Nindhi, welcome to the podcast.
Thank you for having me.
Oh no, it is genuinely a privilege. I just wanted everyone to share a little bit of the Nindhi magic, and your wisdom, because I know there are so many of us around that benefit from it. So look, I thought today we would actually take maybe a little bit of a back step, because we're going to be talking about menopause and perimenopause, and most of the listeners are very much in that. But I think sometimes we lose sight of actually some of the science behind it and actually what is going on. We're so sort of consumed by the symptoms and in how it's affecting our lives that sometimes I think we forget the biology behind it. And I also thought this could be a very good opportunity for you to explain it from a medical scientific perspective, in case some of the blokes in our lives might need a little bit of an explanation, because, you know, they sometimes really need to understand it. So this could also be a very helpful tool, ladies, for your blokes to listen to if they've got any questions.
Yeah, that sounds great. It's a topic very close to my heart.
Yeah, you are the expert in the area. So let's just start right at the beginning. Okay, so what is menopause, and what is the difference between perimenopause and menopause?
So I guess menopause is really a scientific definition that doctors came up with quite a long time ago. And they defined it as the absence of periods for 12 months. So it's sort of a point in time, if that makes sense. But most lay people understand menopause as a larger breadth of time that includes perimenopause. So that's where sometimes the confusion is with patients. What it relates to is a decline in sort of estrogen levels and other hormones connected to the ovaries, and that can happen quite quickly, or it can happen more gradually. And so the perimenopause is a sort of period of time before we reach menopause that on average lasts between 2 and 10 years before the actual time of menopause. And, in Australia, menopause on average happens at about 51 for most women, but I have some women who cycle up to 54, 55. Yes, and some women who stop cycling in their early 40s as well.
Okay, so it's definitely the spectrum.
Yes. And we do have different terms. So we have early menopause, which is sort of between 40 and 45. And then we have premature ovarian failure, which is before 40. So if you go through the menopause before 40, that's considered an actual medical condition. So just to be clear, menopause is a natural, stage in a woman's life. It is not a disease. So just to be clear about that.
Yeah. Okay, absolutely. So perimenopause is often regarded as a bit of a new term, because I know when I started having these conversations with my mother, which probably happened far too late in life, to be honest, and we'll get to that later, she didn't even actually know what I was talking about when I first mentioned perimenopause. So is it something that sort of crept into the vernacular of late to try and explain, to differentiate some of the stages?
Yeah, I think a lot of it has actually come from the fact that, 50% of the population are women. They're under a lot of different pressures now. And so they're wanting to understand what's going on with their bodies. And to be fair to women, the perimenopause hasn't really been well studied. And so it hasn't really been considered a medical issue in the past. So that's really why it's really become more popular, and women are trying to understand what's going on with their bodies.
Yeah, totally get it. So you mentioned that it's to do with the decline in estrogen, and it's also progesterone, I think. Is that correct? When you
That's
mentioned the
right.
other hormones? Yeah. Okay.
We are actually born with the number of eggs, that we have. So we can't really change that over time. And so when we go through the menopause is almost determined to some extent at birth.
Oh, right.
Yeah.
Okay.
Yeah.
Okay. Okay, there you go. Okay. And so the decline in estrogen, actually, let's just talk about estrogen. So what does estrogen do for us? So in our 20s and 30s, when we're sort of having babies and we're highly fertile and living, you can still live life to the full in, 40s and 50s and 60s. But when you're going through that period of life, what does estrogen do?
So estrogen is a gonadal hormone, so it's secreted by the ovaries before menopause, and its primary sort of role is really around fertility. So it helps to stimulate the egg release, and that's why as we age and the ovaries are no longer producing eggs, we get less and less estrogen.
Okay, I understand. I understand.
Yeah.
And then the progesterone. Can you talk to me about that?
Yeah, so the progesterone is actually released from the corpus luteum, which is sort of where the egg has been released from, sort of middle part of the cycle. And that progesterone rises in that second half of the cycle in preparation for a pregnancy. Now, if the
Right.
egg isn't fertilized, the actual progesterone levels sort of decline, and that's when you usually get a bleed or a period.
Understand.
Yeah.
Okay, understand. Okay. And how can both of those hormones make us feel? Like in our 20s and 30s, are they the hormones? So I'm thinking estrogen specifically. If it's responsible for fertility, I suppose it must make us feel attractive and beautiful and sexual and all those things. Is that right?
Yeah, look, I would say that if your hormones are in balance, and this is, it's getting harder and harder for women to keep them in balance because of various factors. But if your hormones are in balance, you should feel quite good throughout your cycle. You may notice an increase in libido around the time of ovulation, for example, and you may also notice that you look and feel more attractive when that estrogen surges. So a lot of women report that. Progesterone itself is actually quite good for our mood, and it also assists us with our sleep quality. And so if your progesterone levels are normal or healthy in that second part of the cycle, you should actually feel really good. And what I noticed sort of more recently is that a lot of women are struggling with adequate progesterone production. So they're experiencing a lot of PMS, which is premenstrual syndrome.
Yep.
And they may discuss things like irritability, anxiety, restlessness, breast tenderness, back pain. And this becomes more and more common as we approach perimenopause and into the menopause. And so I'm seeing a lot of patients that present with worsening PMS as they're getting older.
Okay, interesting. But some of those patterns and symptoms are starting well before perimenopause in that case. Yeah, that's really interesting. Okay, so can I ask you symptoms? So, from where I sit, they've been broad and multifaceted, and, there's brain fog, menobrain, as my friends and I call it. There's insomnia, there's libido issues.
Yes.
Yes, absolutely. Joint pain, moodiness, teariness, anxiety. What else can we add to that list?
So, that's a really good list. So I'm going to run through things. So about 70 to 80% of women will experience hot flushes, but the severity might vary. And most women will notice a drop off in their libido. But I do have some patients who notice the opposite, where it actually increases.
Really?
Yes. So there are some
Wow.
lucky ones out there.
Wow, that is
So this
amazing.
is-
Would you say
this
that's
is-
like 5%? Like is that the
Yeah, it's a
outliers?
very
Let me
small
pull that
number,
up.
but it does
Okay.
exist. I would say that menopause is so varied that not every woman experiences all these symptoms, but they're more common. So definitely sleep disturbance is a big one. Even without hot flushes, I notice women are struggling with sleep disturbance. We tend to get more insulin resistance as the estrogen levels decline. So women start to notice that they're gaining weight without changing anything. And that weight tends to be more central, so around the abdomen.
Yes.
Yeah. And that's very frustrating for a lot of women.
Very
Joint
frustrating. Yep.
symptoms are incredibly common. And at this stage, a lot of women are starting to worry about arthritis because they may have a family history of arthritis. But generally, it responds really well to menopause hormone therapy. So it's not, it's related probably to the fact that estrogen itself acts almost like an anti-inflammatory in our own bodies. And so with the declining levels, we can get inflammation anywhere. So I get a lot of patients with frozen shoulder, for example, or rotator cuff issues, lots of trochanteric bursitis, on the hips, lots of tendon issues, for example. I do notice that mental health starts to really become a big factor here as well. So I get a lot more patients with anxiety sort of showing up, or worsening anxiety, sometimes really low mood. A really common complaint is irritability. So just angry with husbands, partners, kids, struggling to sort of keep a lid on it. Really, really common.
Yeah.
And there are a few women that come to see me who complain about the menobrain. So one of the things that they notice is that short-term memory is an issue. So they just can't remember things like they used to. A lot of patients report feeling more ADHD, and there is some research to support that that can kind of unmask some of those symptoms.
See, just on the ADHD, I was reading
Mm,
somewhere that there is, an increasing diagnosis of women in their midlife with ADHD. And is it related to the drop in estrogen?
yeah.
I suppose the jury is out. We don't know, but there is a pattern there.
Yeah, absolutely. And I think we'll probably hear more about it because both areas of medicine are sort of getting more funding and more research. So we'll probably learn more about that as time
Yeah.
goes on.
Yeah, there you go.
Other things that women complain about are, difficulties with lubrication. So
Yep.
that predominantly affects the vagina. So that can present as pain during sex, and it can present as recurrent urinary tract infections. Some women complain of dry eyes, dry skin, loss of collagen or wrinkles. Is a big thing that women kind of, get very worried about. There's about 120 symptoms associated with menopause. So some patients, report tinnitus, for example, which,
Yes.
and again, we don't really understand the mechanisms for this, but we definitely see an uptick in a whole host of symptoms.
Yeah, absolutely. I was reading and I think it's the Jean Hales Institute
Mm-hmm.
in Victoria. I think it's based in Victoria, and it's I think it's an organisation really dedicated towards women with a real interest in menopause and midlife care. And they did a research study to say that I think women between the age of 45 and 68. Out of those women, 70% of those women are bothered, was the word they used, by menopausal symptoms.
Yes.
And then as one gets older, you are less and less bothered. I think it goes down to 22%. So there's a lot of us that really are, trying to wade our way through these symptoms as random as they are, and need some assistance with it. So thank you for
Yeah.
that. I've got friends that have had ringing in their ears, that have weird rushes. I suppose the question I have to you is, how do you know when something is attributed to menopause, caused by menopause, or whether it is something else? Oprah tells a story you may have heard of, that she had this heart condition. And look, I apologize, I don't know the exact details. I think it might have been a racing heart. And she went from cardiologist to cardiologist. She had test after test after test. And after lots of investigation and a lot of money that was spent, she can afford it clearly, it was actually decided and worked out that this was actually all caused by her hormones going awry with midlife. Is that something you've seen? And how would you manage something like that? It's hard, isn't it?
Look, I think a lot of it depends on who you see first when when you've developed a symptom
Yeah.
and it's in perimenopause or menopause. It really depends on who you see first. And if you see a doctor, I think, that has an understanding of menopause and perimenopause, they may kind of be more aware that sometimes these symptoms are more common. I would generally say that doctors tend to sort of, as a rule, like to rule out serious causes first and then look at other causes. In my patient population, if they are experiencing symptoms of menopause, like if they are experiencing hot flushes or changes in their cycle and it's quite recent, and the symptoms that they're describing are kind of timed in at a similar time, often there's no harm in giving a trial of menopause hormone therapy to see if those symptoms actually change or improve. And then that way we know, okay, look, it's probably related to something related to menopause. And I think historically, when Oprah was going through that issue, menopause hormone therapy had really fallen out of favor. So it wasn't a first line kind of option for a lot of women back then. Whereas these days, the tide has sort of turned. And so, a lot of doctors are more willing to prescribe it as a trial in patients. So I think we'll see less of that as time progresses.
Which is a good thing.
Yeah.
Now, let's talk about, I suppose, the elephant in the room, HRT. So as you said, as you alluded to, for many, many years, it was very much on the nose. It was seen as cancer causing. It was to be avoided at all costs. I remember, because I toe the integrative line, and I love that world, thinking that I will never take HRT when I get to menopause. There's no way. I'd never succumb. I'd never do it. I'd never be weak. And here I am, loving every day of it. Thank you very, very much. But let's talk about it. What was the research? When did it happen? And how did it go so terribly wrong?
Yeah, this is a story about, the power of research and the media and that combination together. So in the 60s, an equine estrogen, so from dried horses, urine, a dried mare's urine, was approved to be used for hot flushes. And so a lot of women who were experiencing this, because up to 60 to 70% of women, experience hot flushes. So a lot of women were put on what we call unopposed estrogen, so estrogen only. And then what they found was that there was an increased rate of women developing uterine cancer. And, now we understand that's because they didn't have any protective progesterone or progestins on board. So there was a big kind of media scare. And so a lot of women dropped out of using their HRT. For the women that remained on it, it was found that it actually improved their bone density and reduced the risk of osteoporotic fractures, I think by 35% or something. But that never made it to the media, if that makes sense. So there was a few women still taking it for that reason and quite happy to continue that. And then in about 1998, the Women's Health Institute decided to do a very big, broad study studying thousands of women. Unfortunately, some preliminary data was released in about the early 2000s. And it seemed to show an increased risk of breast cancer and cardiovascular deaths and incidents. So the doctors all freaked out, and a lot of women were sort of taken off their HRT quite suddenly. And the Women's Health Institute continued to study the women who had come off the HRT as well as the women that continued on it. And then over time, more and more data has out to support the use of HRT, which they now call as menopausal hormone therapy. And that's to distinguish it from that time period, really, because it's exactly the same thing in terms of you're getting an estrogen and a progestin or progesterone.
Sure.
Yeah.
Okay. So the media, they loved it. It's great clickbait, and they had a field day with it.
Yes. Yeah. And the thing about data is it's really hard for even doctors and lay people to interpret, if that makes sense. The way it's presented, it can be presented in a way that seems favorable or unfavorable. So, for example, if you've been on HRT for 5 years continuously, there is an increased rate of breast cancer from 1 in 50 to 2 in 50, 1% to 2%. So, but if you report that as a 50% increase in breast cancer, that can sound really terrifying to women who might have a family history of breast cancer. And so again, it's really about how the data is presented. Yeah.
Absolutely. And because it can be completely game-changing, can't it? It can give women their life back. Like, it's my experience. It opens up the world again. It's like the curtains open. Seriously, it's the curtains open. You get your energy back. You've got your mojo back.
Yeah.
It is, in my case, it was completely responsible for me just restarting my life. So I'm very grateful to you for helping me through that.
I do want to make a few other points about the study. So what they found with that WHI study was that the women that were studied were actually much, much older than the typical woman using menopausal hormone therapy now. So I think the average age was about 63, whereas if you look at modern day prescribing, most women are started on HRT or menopausal hormonal therapy in their late 50s to kind of early to mid 50s.
Sure.
Yeah, and it's much safer when we start it within 10 years of menopause.
Okay. But if you wanted to start it after 10 years, the risks actually are greater?
Well,
or the benefits not
with
there?
this particular study, what they found was there was more cardiovascular deaths and heart attacks and things. So we have got patients who do start HRT or menopausal hormone therapy after 60, but usually we would want them to see a cardiologist and just ensure that there wasn't any sort of subclinical cardiovascular disease that hadn't been picked up. One thing to note, which is really interesting, is that women who tend to get severe hot flushes, so debilitating hot flushes, are more at risk of subclinical cardiovascular disease. So if you are a patient that is experiencing severe hot flushes, it might be worthwhile getting an earlier sort of review with a cardiologist.
Yeah, okay, that's good advice, actually. That's good advice. And what percentage of women, from your experience, do really experience those intense hot flushes, debilitating hot flushes?
In my practice, I would say, maybe 15%.
Okay, yep.
And I would say the majority of patients, like 80% of patients, usually those symptoms will abate within 5 years. But about 15% of patients continue to have kind of disabling hot flushes for their lifetime. And so I do have some patients in their 70s who are still on menopausal hormone therapy.
Wow. And actually, that's my next question. How long can you stay on it for? The rest of your life?
I think it's patient dependent, to be honest. But from the research so far, and as you know, this is updated continually.
Yeah.
From the research so far, we have noticed that there is a slight increase in risk of breast cancer. As I said, 1% increase, like 1 out of sort of 50 increase if you've used it for 5 years. And then that doubles if you use it for 10 years.
Right. Okay.
And after stopping that, there is a slight increase for the next couple of years as well. So for somebody that's particularly concerned about breast cancer, they may choose to only use it for 5 years, for example. They may feel for them that risk is too much.
It's too much,
But
absolutely.
if they have
Okay.
no family history of breast cancer, they're not overly worried about breast cancer, but they're more interested in, for example, cardiovascular risk or bone health, they may continue it sort of for much longer. So at this
Yeah.
stage, we sort of talk to the patient on an individual basis and decide whether or not they'd like to continue.
Understand. Okay, absolutely. So just to clarify, so it can absolutely and utterly affect quality of life, but it also can work really positively towards prevention. And you
Oh.
mentioned quickly osteoporosis, so bone health, and then cardiac health as well. Can you talk a little bit about how that could work? Is it the estrogen there that it plays the role, or is it both of the estrogen and progesterone?
We feel that it's the estrogen because those benefits are also seen in women only taking estrogen. It also reduces the risk of colorectal cancer, which doesn't
Okay.
really get picked, it doesn't mention much, but that definitely is the case. At this stage, unfortunately, we don't have any data on whether it reduces the risk of dementia.
Okay.
Even though a lot of women do report they feel less brain fog
Mm.
once they've started HRT. It doesn't seem to reduce the risk of dementia yet. But again,
Okay.
that's something that we have to study for up to 20 years to really have the data on that.
Yeah, I
Mm.
understand. So look, there probably are still some people who have got reservations about HRT and you do you, that is no problem. So if you fall into that category, or if you are one of those people that can't tolerate HRT, what else can be done in your experience? I mean, are there any other natural integrative solutions if you put your integrative hat on for a moment? What
Yeah.
else can women do?
So, first of all, I just want to point out if a woman is struggling with menopause hormone therapy, so they're not tolerating it, so they're getting lots of side effects, it's worthwhile looking at how they metabolize those estrogens. So, sometimes it's not an issue with the estrogen per se, but actually how their body metabolizes that. And so, with my patients, if they're struggling, we can organize testing to look at how they might metabolize those estrogens. The other thing that I've noticed, and this has sort of come through working with patients, is my more neurodiverse patients, so the ones that sort of may have a diagnosis of ADHD or autism, can really struggle with hormones. So sometimes it can have a paradoxical effect on their brain and make them feel worse
Right,
from
interesting.
a mood perspective. And so that's something just that I've noticed. And so they may choose not to use HRT or use lower doses or for those patients. And then the other thing is liver. As we get older, our liver's sort of been exposed to a lot more toxins, and detox pathways may be a bit sluggish.
Mhm.
So I sort of see menopause or perimenopause as sort of a really good time to do course correction. So any
Okay.
of those bad habits that we've been hanging on to in terms of lifestyle, it's a great time to sort of really look at that and see where we can change things. There's been a lot of studies showing that women that have a healthy lifestyle, so regularly exercise, whole food diet, that sort of thing, definitely have less menopausal symptoms.
Okay.
Yeah, non-smokers do better than smokers, for example. Non-drinkers tend to do better than drinkers. So
Right.
I just want to make that that because inflammation levels seem to go up around perimenopause, menopause, I always recommend an anti-inflammatory diet.
Okay.
And I've had patients who have chosen not to go on HRT, but their joint symptoms, their arthralgias, their inflammatory symptoms have actually gone away just using that alone.
Wow. Okay.
So that's been really powerful.
And just on that, are you referring to
Mm.
like a Mediterranean style diet when you talk about an anti-inflammatory diet?
It's similar to a Mediterranean style diet, but it's called the anti-inflammatory diet. So,
Oh,
but very similar. So you're trying to reduce sort of, saturated fats, rancid oils, processed meats, all the things that
sure.
we've talked about. Yeah.
I know that I'm a little bit. I feel like I'm always the outlier, and I don't know where I fit into that category because I couldn't tolerate HRT, like the normal estrogen, the smack bang patches that you get from the chemists,
Mm.
because I think I have something called estrogen dominance. Is that correct? Where I've got issues with pathways and detoxification.
Yes.
Is that?
Yes.
And so I suppose there are some women that fall into that category that therefore wouldn't want to do H.
Yeah, I think as time goes on and people understand their bodies more, we'll be able to use HRT differently. Currently, there's only one formulation of body identical estrogen available, sort of as a patch or a gel. And so women are sort of limited in terms of what they can use from that regard. But historically, we have been able to use other versions of that, of that estrogen, which is slightly weaker and
Mm.
might be better tolerated in some women. But we just don't
Yes.
have as much data in terms of is it protective for bone health and other things. But in terms of
Sure.
hot flushes and things, it usually can work.
Yeah, okay.
Yeah.
That's excellent. That's excellent. Okay. And what about in terms of supplements and, things you can buy from the health food store or on iHerb or do you have any top recommendations for people or is it not a one size fits all?
It's definitely not a one size fits all, but I generally find that, like, depending on what the issue that the woman presents with, because generally women will come in with sort of predominant issues. So, for example, if somebody has hot flushes and doesn't want to take HRT, we actually have other medications available to support hot flushes. So, something like Veoza is the current one that works incredibly well. In the past, we used to use something called clonidine. But from a more natural perspective, my patients tend to do really well with sort of using phytoestrogens. So switching to more soy-based products, for example, and it definitely doesn't cause breast cancer. So I want to just sort of put that out there.
Yep, good.
I really love the herb shatavari, for example, for hot flushes. If you've got significant mood issues, there's been some research using St. John's wort, but you've just got to be careful if you're on other meds. So if you are choosing to use something like that, you must check with your GP.
Mhm.
And for some of my patients who have mood issues, once they've gone on to HRT, if they've still got significant anxiety or mood issues, sometimes they choose to take an anti-anxiety medication, like an
Sure.
SSRI, for example. For patients that experience sort of very dry vaginal symptoms, we
Yep.
can use a low-dose pessary or cream of estrogen if the patient feels comfortable with that, and that often works very, very well. We also now have something else on the market that stimulates sort of a DHEA compound, and that can be really great for women who want to, who are wanting to get a better orgasm quality, for example.
Good.
If you don't want to use hormones, then we have some great alternatives. So some of my patients use sort of like an olive oil beeswax compound.
Okay.
Vagisil is something available over the counter that's sort of a hyaluronic acid, for example. And some patients, not all, but some patients do benefit from laser. But again, the research is still out on that one in terms
Hey.
of
And now you've got me intrigued. So with the laser, is the laser going to rejuvenate? Is it going to tighten? Is it going to what does it do?
it
You piqued my
rejuvenates. It
interest.
rejuvenates and allows for better lubrication. Yes,
Okay.
but it's
Right.
not a consistent benefit. So I tend to I wouldn't recommend it in a patient unless they felt really concerned about using vaginal estrogen yeah. We have a lot of patients obviously that's experience low libido. And so there is some, again, low quality evidence for using maca root. So that's a really simple thing to add to coffee, for example.
Mhm.
And in the US, there is a product that's been approved for the use of hyposexual disorder in
Okay.
women. It's not yet approved in Australia, so don't ask your GP about
Okay.
it,
Okay. Okay.
but
But maybe soon?
it may
Soonish?
be coming.
Okay. It's not female Viagra. No, clearly not.
Well,
That's already out.
it's not exactly that, but that's what people call it.
Can I just ask you, there is a female Viagra, isn't there?
Not in Australia.
Right. Okay. So
No.
this is what this would be.
Yes, yes.
I
Okay.
understand. Okay. Thought that was available.
It's really common to get bladder symptoms. So what women describe as sort of irritable bladder. So they might just feel like they need to, pass urine frequently, or they get a bit of urge incontinence. And again, we can use estrogen obviously locally through a pessary or cream, but there is also a medication called oxybutynin that we sometimes use in those patients. So again, you can see that sometimes the symptoms can vary. And so, we sort of tailor the treatment
Of course.
accordingly. If you've
Yeah.
got a lot of anxiety and stress that's sort of building up, I really love ashwagandha and
Mm.
L-theanine. They're kind of my two favorites for that one. If you've got the joint symptoms, for example, I usually add a little bit of curcumin, and I find that really helpful alongside the anti-inflammatory diet. If cognition is an issue for patients, I generally recommend they see a good herbalist because we have quite a few compounds that can assist, like Dan Shen is a really good one, and Bacopa.
Okay. Yep.
And for the skin, because a lot of women start to worry about aging, obviously.
Yes, obviously.
So we have retinol creams available to assist with fine lines.
Okay.
For dryness, I really love tallow. I don't know if you've tried that
No.
yourself.
Do you mean beef tallow?
Yes.
I think that was big on TikTok a while ago and people were actually immersing themselves in tallow they'd cooked from beef. Oh, that's obviously not what you're referring to.
Well, look,
Different form.
You can buy tallow from, butchers, obviously, but I tend to
Mm.
sort of recommend you, purchase it from a beauty company and without any sort of perfumes or anything like that. And it can be
Odd
quite
smells.
moisturizing. And there has been some research showing that collagen can actually help with fine lines and wrinkles. So
Mm.
2.5 grams a day in very small studies. So you have to understand, they can't do the studies like the drug companies
Sure.
can, for example.
I understand.
In terms of insulin resistance, we
Yep.
mentioned that being a big issue for a lot of women. So some women choose to use the new peptides, so, semaglutide or
Yep.
tirzepatide, and, uh, that can actually assist sometimes with brain fog and energy as well.
Mm-hmm.
But, we have a lot of herbs and nutrients that can assist as well with that. The only warning I should mention, though, is there has been a lot of talk about black cohosh. And I would say that, again, there hasn't been any good quality evidence that that does work. And it is a real issue if you have a liver issue.
Okay.
So if you've never had your liver function tests done, I would really steer away from that. And if you are choosing to go on that, because it is available over the counter, I would definitely
Yes.
have your liver function tests checked sort of fairly frequently while you're on it, because we have had some hospitalizations and things.
Right. Okay. Okay.
And then I think the last thing I'll mention is hair loss. So
Okay.
unfortunately, a lot of women do sort of struggle with hair loss during this time period. One of the most common reasons is actually iron deficiency, because often they're getting, heavier periods, losing a lot of iron, not able to keep their iron levels. And so they often lose a lot of hair at that stage. So in that case, we would sort of work on how to reduce the blood loss and replacing the iron. But
Okay. Can I just ask you quickly?
yeah,
And does thinning fit into that category as well? Thinning of hair before we get to the hair loss?
yes. So
Yes.
if it's
Yes.
thinning and it's
That's
often
happening.
hormonal,
Right.
we have a lot of options available. So for women that don't want to take medications, saw palmetto can assist.
Okay.
So
Good.
it's a herb, and it was initially used for prostate, so large prostate, but it was also researched because it blocks the conversion from testosterone to dihydrotestosterone. So it
Right.
can be used for hair loss that's hormonally based. But we have some great medications for hair loss. So, and the trick is to get in early. So don't
Okay.
wait till you've lost so much hair that you're really worried about it. Come
Yep.
in early. Talk to your GP. They can prescribe those medications, and if they're uncomfortable about that, they can refer you to a dermatologist. But they
Yep.
work really well in a lot of patients.
Great. So good to know. So good to know. So if there are blokes listening to this, and I first of all, I want to welcome you to the Grown Up Girls Report, guys. Thank you very much for tuning in. But if you just had, 50 or 100 words to share with the blokes that are listening and that are keen to support their wives, what would your 3 top tips to these men be?
3 top tips. Okay. So I think first of all, I would say that a lot of women feel quite vulnerable during this time. So I think as a partner, it's really important to sort of, validate their vulnerability and give them reassurance. Um, especially if they're struggling with things like libido and, physical appearance and things like that. So just being really kind and gentle. I think educating yourself about what perimenopause is and the fact that it can last for, 10, 15 years.
Mm.
So it's not,
Mm.
it's not just a short-term thing. So just equipping yourself with what they can experience so that you become a support role for them. I think, because a lot of women are still trying to work it all out, and they can get really
Mm.
overwhelmed with all of it. What else would I say? I would say stop snoring. Get your snoring fixed.
Yes, please. Get that. Yeah. Sort
Because
yourself out too.
sleep becomes more elusive for women at this stage of life. And so the snoring really is just intolerable. So please go and get it fixed.
Or move into the spare room.
That's
You know?
right.
Be kind.
Yes, I think sleep divorces are becoming more popular these
Yes.
days from what I hear. So,
Yeah. No,
yeah.
that's really good advice. And is there anything we haven't talked about today that you think we need to just pop in? Any other words of wisdom that you can share?
Yeah, look, I think from, just from a spiritual perspective, like looking at menopause. So I think aside from whales, we're the only mammal that experiences menopause. So it's very unique, it's very unique to us. And I think historically, Western society in particular has sort of, been a bit reluctant to acknowledge and accept the menopause. And there's a very negative view of it. And personally, I feel that we need to change that narrative and see it as a really great opportunity for course correction, figuring out what we really want in our lives, figuring out how we want to live our lives, having more breathing room, to allow us to kind of live out our dreams. Because a lot of women are in that sort of sandwich between looking after parents, looking after teenagers, things like that. And I think, in Eastern kind of philosophy, they describe it as the second spring, which is such a beautiful way to look at it, because it's a time to reinvent yourself. Whereas I think with Western philosophy, they look at it as a second puberty, which nobody liked puberty. So
No.
sort of just showing you what different cultures and how they view it as. So, the main point I'd like to say is that women are incredibly intuitive, and this is a really good time to tap into that intuition and really feel what they need, and really listen to that voice.
I really get that. I just think as well, for so many women, they find their voice as well during this stage. And I remember when this whole journey started for me, probably, I don't know, 8 or 10 years ago, I was seeing this wonderful massage lady, and she's probably 15, 20 years older than me. And she was sort of saying, I think your DHEA is off. Anyway, and she said to me, don't worry. She said, it's all ahead of you. Spring and summer, it's just magic. This is going to be the most incredible time in your life. And she said, no, it's not the end of the world. This is the start of something magical. And I often reflect on those words, particularly when I'm not having a magical day.
That's right.
But there are definitely positives here, aren't there? It's not all bad news. I mean, yes, there's some bothersome symptoms, as all the research shows, but doesn't have to always be a negative experience.
No, it doesn't. And I think if we just sort of slow down a little bit during this time and really ask ourselves, those important questions like, what have I done for myself today? What didn't sit right today? How can I do better tomorrow? Because I think sometimes I've just found a lot of women are just rushing. They're not sitting and reflecting about themselves, and they're just sort of staying in those caretaker roles. And this is a time to sort of move beyond that a little bit, and be a little selfish.
Yes. Say no. I don't actually want to go out with you.
That's right. Get rid of those toxic people and,
absolutely.
Do things you love, because I think the other thing that I've noticed is there's a lot of women that feel a lot of pressure to sort of, they've got to do 3 sessions of resistance. They've got to do this right and eat protein. And, the list goes on. And
huge list.
Yes, exactly. And so many women feel completely overwhelmed by this. And what I would say is that, when we look at end of life, people aren't saying, oh, I'm so glad I did those 3 HIIT sessions every week. And I'm so glad I did this. And I'm so, they're generally, talking about their relationships, their life purpose, they're talking about bigger things. So I think if you can get those bigger things right, the other things will kind of fall into place in a way that you need. And so just trust that intuition.
I love that. Thank you. You're a wise woman. Nindhi. Now, Nindhi, if people have got more questions, where should they go? Is there a great resource that you can recommend?
There's a couple, actually. So if you are looking for some fact sheets, that are science-backed, or some practitioners that are interested in menopause, then the AMS website's good. So Australian Menopause Society. Dr. Louise Newson is a UK GP that a lot of people already know about, but she also has an app called Balance, which is free and gives you a lot of information about menopause. There is an Australian GP that wrote a book called How to Thrive in Menopause, and her name's Dr. Ginny Mansberg. So some of you may already be familiar with her, but she kind of lets you know about all these options in more detail. And for those of you particularly interested in the menopause brain, Lisa Moscani wrote a book as well, and she's obviously been interviewed on a few podcasts. So, but talk to your GP, and if your GP isn't comfortable or isn't sure, they can always refer you to someone that is.
Yeah. Okay. Fantastic. But there is help. There is help there, isn't there? And I have found in Instagram and TikTok, actually, as long as you're listening to the right people, as long as these people have science creds, it can be a great source when you are just trying to navigate your way through something. So
absolutely.
Anyway, thank you so much for your time today.
Thanks, Alex.
No, you're a star. Thank you so much. Great words of wisdom. And thank you to all the blokes that have joined us today. Welcome. Spring and summer are just around the corner, I'm sure. So thank you very much, everybody, and we will see you next time.